He has his medical degree at McGill, has done postgraduate training in cardiology. He's done multiple fellowships and has a PhD from Erasmus in Rotterdam, and is really one of the leading experts in transcatheter aortic valve and now in imaging of both transcatheter aortic and mitral. So he's going to share with us today state-of-the-art imaging of the mitral valve. So thank you, Nick.
Thanks, Anita. Okay, so I think it's very interesting to note that in the field of transcatheter mitral valve repair and replacement, there's at least 54 companies, 28 repair and 26 replacement devices. And as we'll see some of these devices here, we'll begin to understand that the imaging becomes very device specific. When we image the aortic valve for TAVR, we basically measure all the same things for all different devices. We measure the annulus and the sinus of Valsalva and coronary heights, etc. But as we move into the mitral space, we'll see that every valve repair or replacement really requires a specific imaging approach. There's at least 16 devices in the repair space with first-in-man experience. Whether it be an edge-to-edge or a direct annuloplasty, chordal repair, or something that enhances coaptation. And at least in Europe, there's about 5 devices that have received CE mark approval. In 2008 was the Mitral clip. In 2009 came Cardiac Dimensions with an enhanced prosthesis in 2011. The Neocord came out in 2013 specifically for degenerative MR. The Cardioband in 2015, and Mitraline in 2016. And again, the imaging requirements, whether it's the pre-procedural or intra-procedural, are extremely different from device to device. So one talk to cover how to image the mitral valve by CT or by echo really covers only really a fraction of the field. And these are all the different types of transcatheter mitral valve replacements that are that have been implanted in humans or are very close in going into humans. Really, it started back in 2012 with the first cardiac device. And then 2014 was really the year of the replacement, where Neovasc, Edwards Fortis, Cardiac came up with their second generation, Tendyne and 12, now associated with Medtronic. Went into first-in-man. In 2015, we saw some additional valves in first-in-man. Cardiac went with their second-generation transeptal, Navigate, and M-valve, and 2016 with HighLife. And there's approximately about 108 transcatheter mitral valve replacements performed worldwide up until PCR. And when we think about imaging of the mitral valve, really you have to try to understand the interaction between fluoroscopy, echo, MRI, and CT. And I showed this message earlier on today, but it's worth repeating. Again, we need to understand how to translate the cardiac anatomy across the spectrum of imaging modalities. So what you see on the left-hand side is a 3-chamber view of a heart specimen, but that same 3-chamber view can be obtained on echo, on fluoroscopy, on CT or MRI, and we're always seeing the same thing. So the mitral valve is complex, as we know. It's dynamic and it's extremely variable. You can see here from this image of the mitral valve from the ventricular view that it's going to be very important to understand the systolic and diastolic dimensional changes. And just to give you an idea that when we're screening patients for transcatheter mitral valve replacement, if you do not assess for LVOT obstruction during systole and diastole, you will get into trouble. It's complex because there's a lot of surrounding structures that we have to begin to think about. There's the pulmonary veins, there's the left atrium, of course there's the leaflets, the cords, the patent muscles. There's tons of trabeculae in the left ventricle, there's LVOT, there's the aortic valve. So somehow we have to understand all of these structures and how they interrelate to each other, not only before the procedure, but also on fluoroscopy. And we mentioned that it's variable. These are different heart specimens, and this is a sample taken from a publication back in 1978 in Circulation. And it really went across the variability that is found in the mitral valve. You could imagine that trying to understand the different types and amounts of papillary muscles that are emerging from the ventricle is going to be somewhat important for particular devices. And the question is, how are we going to understand all of this variability? Is it going to be echo? Is it going to be CT or MRI? And imaging really starts off, of course, with its importance in patient selection, and then moves on to prosthesis selection, access site selection, and procedural guidance. This was a paper that we published in 2014 and really was an eye-opener for us in order to understand the fluoroscopic anatomy of left-sided heart structures. And let's take this short axis view of the mitral valve. You see there the A1, A2, and A3 components highlighted by white arrows of the anterior mitral valve leaflet. And you see P1, P2, P3 of the posterior mitral valve leaflet. Now, the blue and red arrows indicate a particular view of the mitral valve. So let's look at the mitral valve from the blue perspective. And this would lead to a RAO caudal view. So remember this morning when we talked about the aortic valve, we said that every time you go into an RAO caudal view, you end up in a three-chamber view of the heart. Now, if you look at from the perspective of this blue eye, so let me go back here. You can imagine that the anterior and posterior mitral valve leaflets look like two separate columns, okay, from that perspective. Okay, and of course, when you look at a three-chamber view, you nicely separate the anterior from the posterior mitral valve leaflet. And what you also appreciate is that in this view, your segments of the anterior mitral valve leaflet, so A1, A2, and A3 are overlapped. So if we move over to the fluoroscopic view, of course, that three-chamber view allows us to understand where the anterior and posterior mitral valve leaflets are, but you have an overlap of the A1, A2, and A3 segments of the mitral valve and also those of the posterior segment. In the three-chamber view is also the view where you have a nice separation of your aortic and mitral valve leaflets, and you also have overlapping papillary muscles. Now let's look at the view from the red perspective. This would be a more shallow areocranial view, and this is a two-chamber view. So this is the exact same two-chamber view you would get on echocardiography. And you can see on the complete right-hand bottom corner on the fluoroscopic image, you see that typical commissure to commissure view with that left atrial appendage on the lateral border of the left atrium. So if we concentrate again on that top left-hand image and look at it from the red eye perspective, now what we'll see is that we'll have the anterior and posterior mitral valve leaflet overlapping each other. Okay? But our red eye, will be able to distinguish between the first, second, and third segments of the mitral valve leaflet. So if we shoot over to the fluoroscopic two-chamber view on the bottom right, we can see that we don't have the separation of the anterior and posterior mitral valve leaflets, but we have segmentation of A3, P3, A2, P2, A1, P1. In this view, we also have overlap of the aortic and mitral valves, and we also have maximal separation of the papillary muscles. So all of this information is extremely important when you start manipulating devices in this area. We spoke about the S-curve of an annulus, and the S-curve of the annulus provides an RAO, an LAO, and a respective cranial and caudal view where the annulus is always in plane. And you can ride along this mitral valve S-curve, and all of those points on that S-curve provide the mitral valve annulus in plane. The difference is that you either end up with a three-chamber view or a two-chamber view of the mitral valve. If you're in the extreme areocaudal or extreme eleocranial, you'll have a three-chamber view. If you're in more of the shallow areocranial view, you get that two-chamber view. And the en face view of the mitral valve is in a eleocaudal, and this morning we saw that the en face view of the aortic valve is in an areocranial. So what we'll do here is go over a typical CT analysis of the mitral valve. Okay, so we select the mitral valve complex protocol. This is fluoro-CT. So the first step, it asks you to identify the mitral valve annulus. So you see in the top left hand, we're rotating around the mitral valve and we're selecting the hinge point of the mitral valve between the left atrium and the left ventricle. So we're just wrapping around the mitral valve. Right now we're at the A2 component. And now we're going to the left trigone. And now we're putting a point in the two-chamber view at the commissure level. And we're putting our final point somewhere between the commissure and P2. Okay, so now we've generated the three-dimensional nature of the mitral valve, and you can see it very nicely on the fluoroscopic view. Okay, and the next step is the program asks you to identify the papillary muscles. So we scroll down along the plane of the mitral annulus, and you see on the fluoroscopic side, on the right-hand side, as we put points on the tips of the papillary muscles, it automatically identifies the distance from the papillary muscle head tip to the mitral valve annulus. So of course, the mitral valve annulus measurements become very important for prosthesis size selection. And the distance to the papillary muscles is also very important because sometimes our mitral valve prostheses can impinge really on the papillary muscles and cause some dynamic stress. Once you identify the papillary muscles, the program asks to identify the aortic valve. And the reason why we identify the aortic valve is because we want to measure the aortomitral angle. And the aortomitral angle becomes one of the many factors that is important to evaluate for LVOT obstruction. So the only view to measure the aortomitral angle correctly is when both the aortic and mitral valve are both in plane. And that's when you identify that double S curve of the aortic and mitral valve. And we can have a discussion more later on about what is an important aortomitral angle to avoid LVOT obstruction. The next step is to identify the LVOT. So here you see that we really come to the point where the LVOT starts to spread into the left ventricle. So we're identifying our LVOT. I take note of its area because eventually we're going to do a virtual implant of a transcatheter valve. Now, this was the protocol we were using for cardiac. Cardiac is a device that extends into the left atrium, so it was very important for them to understand where that left atrial appendage is. So here we're highlighting the left ostium of the left atrial appendage, and it automatically generates the distance from the left atrial appendage to the mitral valve annulus. The next step in the program asks if we want to import an STL file. So here we're importing a generic mitral valve, and we align it within the mitral valve annulus, and we'll switch from a fluoroscopic to a three-dimensional endovascular view. And what you see here is a two-chamber view, and we now go back to that LVOT we created, and you see that our prosthesis is protruding into the LVOT. So now we're going to reanalyze our neo-LVOT, and you see that now we're going to wrap around the struts. And again, there's a lot of discussion about how much LVOT obstruction can you support before you get an important gradient. But right now we're using 50% of the area. Once we do this, we can generate a report. First, it gives you a few of the cartoon images of all the measurements you've created. Then you get the S-curve of the aortic and mitral annulus and the two-chamber and three-chamber views, and then you get a few snapshots of the implantations and measurements you've made. So this shouldn't take you 25 minutes. After a few tries, I think within 5 minutes you can do a whole mitral valve analysis with reports. So this is a typical, but of course a generic way of evaluating the mitral valve using CT. So here we have just some other features. So once you generate the mitral valve, you can generate its S-curve. And you see now we're running along the S-curve of the mitral valve in the lower left-hand corner. And as we drag our cursor across that green graph, which is the S-curve, you can see that the mitral valve always remains in plane. The only thing that changes is whether you're in a two-chamber or three-chamber view, really. Now, there's different ways to measure the mitral annulus. Jonathan Leipzig from Vancouver has, has looked into the idea of maybe looking at this as a saddle-shaped versus D-shaped annulus, and again, it differs from device to device. So on the right-hand side, you're sort of cutting out the A2 segment and just going from trigone to trigone. On the left-hand side, you maintain that aortomitral continuity. With respect to LVOT obstruction, again, it's not only about the aortomitral angle. You got to look at the LVOT dimensions. You got to look at the LV dimensions. I think the LV function is of paramount significance. If you have someone with an EF of 50%, very high risk of LVOT obstruction, even if you think the dimensions are okay. And of course, you have to take into account the anterior mitral valve leaflet length, the prosthesis width, prosthesis depth, and the prosthesis orientation. The other important thing to consider is access routes for transcatheter mitral valve repair or replacement. Of course, many of these procedures are being performed through a transapical route for replacement, and many of the repair through a transeptal route. Very few procedures have been performed through a transatrial route. And when we look at the evaluation of a patient for access, for instance, we can identify the inferior vena cava here, highlighted in blue. We can identify the atrial septum, highlighted in green. We can find the angle between their axes, as you see there. And then you can move on and say, let me understand the angle between the atrial septum and the mitral valve annulus, and you understand that angle. And then you can put all of this together, and now you have the inferior vena cava in blue, the atrial septum in green, the mitral valve annulus in blue, and you can really identify which view, in this case it would be an LAO3, cranial 34, in order to understand what path your delivery catheter is going to take. You know, if you ask an interventional cardiologist whether it's coronary or structural, and you ask them, you know, in this particular patient, we're going to go into an LAO 35, cranial 40, and ask them to identify where the papillary muscles are going to be, where's the mitral valve annulus, where's the aortic valve annulus, where's the left atrial appendage, where are the pulmonary veins. You're going to get a lot of, you know, people not really understanding really where all of these structures are, because in the coronary field, we're very much attuned to working by pattern recognition. But now we haven't developed that pattern recognition yet because we're dealing with a whole bunch of new structures in this field. We've also seen the use of 3D printing in transcatheter mitral valve replacement, and you know, the usefulness of this is yet to be determined, but many of the companies, at least in the first in human, are using 3D prints in order to understand how their devices are going to lay in the human anatomy. And with this, I'm going to come to an end. It's a little bit early, but I think it's going to be good to generate some discussion and have some questions from the audience. Thank you.